Hi, and welcome back to ST3 Hacks. And today I'm going to go through clavicle fractures as we start our shoulder and elbow series. I will be going back to the hand section later on in this podcast to cover operations and approaches, but let's crack on with clavicle for now. So when this comes up in the ST3 interview, you should remember that it's not just a shoulder or clavicular injury. Interviewers are often testing whether you recognize the neurovascular and thoracic risks and whether you can structure management safely rather than defaulting to is it a sling versus a surgery? Okay. So the key anatomy and stabilizing structures around the clavicle. Laterally, the clavicle is stabilized by the coracoclavicular ligaments. Okay. There are two, the conoid, which is more medial, and the trapezoid ligament, which is more lateral. I remember this as C is higher up in the alphabet and therefore is medial, and T is further down, so lateral. Medially, the stability comes from three ligaments: the interclavicular ligament, the costoclavicular ligament, and the sternoclavicular ligament. Classifications. I think you can briefly reference classifications without dwelling on them, and there are two main ones that you should know. The Ullmann classification divides the fractures into thirds, so the lateral, middle, and medial third. The middle third is the most common place for the fracture because it has no muscle insertions. The second classification is the Neer classification, N-E-E-R, and it applies to lateral end fractures, and it's based on the disruption of the CC ligaments, which determine stability. You need to think about associated injuries with clavicle fractures, and these can be bony injuries, particularly first rib and multiple rib fractures, neurovascular injuries, including the brachial plexus, damage to the subclavian artery or vein, and then thoracic injuries, especially pneumothorax. When we come to the radiographic assessment, you should start with plain radiographs, which you'll often be given in the interview. And on the X-ray, you can comment on which third of the clavicle is fractured, the degree of displacement, shortening, particularly when it's greater or less than 2 centimeters, presence of comminution, which suggests high energy mechanisms, and any other bony injury that you can identify. Other views to sprinkle in are the 20-degree clavicular cephalad or caudal tilt view, which tells you about superior and inferior displacement. You can also ask for the serendipity view, which looks at the SCJ more specifically. The patient here is lying supine and the X-ray beam is at 40 degrees upwards angle, looking into the sternoclavicular joint. Key concerns here should be about identifying neurovascular injury and lung injury, particularly in pneumothorax. So your triple assessment here will start with the ATLS protocol. So you should say this is likely high energy mechanism and should take an ATLS-based approach, including examining and listening to the chest to exclude pneumothorax. In the history, you need to ask about the mechanism of injury and ample history, and you should also take a focused social history, looking at hand dominance, occupation and hobbies, and smoking status. In the examination, you should use a look, feel, and move approach as always, assessing for open injury, inspecting the skin for tenting or threatened open fracture, including buttonholing through the platysma muscle, checking the degree of shoulder movement that's tolerated by the patient, and performing a careful neurovascular exam, including the radial, ulnar, median, and axillary nerve function. Investigations, as we've discussed, you've got the AP cephalad tilt views to assess superior and inferior displacement. If there's any concern about thoracic or mediastinal injuries, consider a CT scan, specifically when assessing for lung injury. In the immediate management, you should say, I would provide a broad arm sling, ensure adequate analgesia, and begin perioperative workup if surgery is likely. If there is a threatened open fracture, then you need to inform the consultant early on, as it would then be treated as an open fracture with Bose guidelines. Let's discuss definitive management. Now, most clavicle fractures are managed non-operatively, but there are absolute and relative indications for surgery. There are 5 absolute indications: open or threatened open fractures, vascular injury, significant shortening, typically greater than 2 centimeters, polytrauma patients, and lastly, a floating shoulder. Relative indications include heavy comminution, symptomatic malunion or non-union, and lastly, professional or high-demand patients. It's a very common question to be asked about how you're going to consent the patient for this. So again, you should break down consents to general surgical risks, including pain, infection, bleeding, neurovascular injury, stiffness, malunion, non-union, further surgery, thromboembolic events. And then procedure-specific risks for clavicular surgery include hardware prominence, with about 30% of patients requesting removal, altered sensation over the anterior chest wall due to supraclavicular nerve injury to the subclavian vessels, a pneumothorax, and adhesive capsulitis. There is also evidence that you can sprinkle on into your interview, which is the Canadian Orthopedic Trauma Society's RCT, which showed fewer non-unions, fewer symptomatic malunions, and quicker time to union with operative fixation. Talking about post-operative and follow-up care, you should say that typical milestones for patients include wound review and pendulum exercises at 2 weeks. At 6 weeks, they should progress to weight-bearing physiotherapy, and at 12 weeks, they can return to full activity, including sports. A delayed union is a failure to unite by around 6 months, and a non-union is an arrest in the fracture healing process, normally classified around 9 months. Broader interview tips here are that interviews may now test competency outside of the surgical SPR brain. So they may ask you to focus on SHO, CCRISP protocols for perioperative and postoperative management. So in this case, for example, they can ask about lower respiratory rate postoperatively and what you're going to do, a pneumothorax and how would you manage that, or a patient has symptoms of a PE and they may present you an ECG with obvious signs of a sinus tachycardia or a S1 Q3 T3 classic finding. And if you don't forget your SHO knowledge, basically you will be at a competitive advantage from those really senior trainees who haven't done any kind of general surgical ward medicine in ages. So make sure you don't lose that touch. That's it for this episode of ST3 Hacks, and I'll see you in the next one.